Yes, I'm just about to start the session.
Hello, can you guys hear me? Hello? Hello?
Yes, Doc, we can hear you.
Yes, we can
Okay,
hear you.
okay, perfect. Perfect. So
Yes.
let's start our today's session. First of all, let me just share my screen. Okay, so yesterday we discussed something about microcytic anemia. So anyone who can just give us a quick roadmap of what we did today so that it's like going to be easy for us to continue our further discussion. Anyone who can just quickly tell us the main idea of microcytic anemia, as you guys had a lot of MCQs in UWorld today as well. So we are going to take this info, like this discussion a little bit further. So anyone, please raise your hands.
Yeah,
Those
I
who want
can.
to. Yes, please, Dr. Shafiq. Yes, please carry on.
Yeah, microcytic anemia, usually the indicator for it is the mean cholesterol volume, which is less than 80.
Okay, perfect. So we discussed we have microcytic anemia, and how do we classify micro small? That is whenever the MCV mean corpuscular volume is less than 80. Okay, so we discussed that whenever we have like decrease hemoglobin, any reason, any cause which lead to decrease hemoglobin would lead to microcytic anemia. Why? Because the red blood cell would try to compensate this less red blood cell in a way that it would just undergo an extra division. We discussed it, right? Extra division. Okay, we already discussed that hemoglobin is basically made of heme. Okay, hemoglobin, we discussed it's made of heme and globin, right?
Yes.
Okay, so we discussed we have our heme and we have our globin.
Grouping.
We discussed that furtherly heme is formed of your iron and
And
protoporphyrin, right?
protoporphyrin, yes.
Perfect. And we discussed that we have different globin chains, our alpha chain and beta chains, which we'll be discussing, right? So we discussed, for example, if we have less iron, it can be due to two things which we discussed yesterday. It can be due to nutritional deficiency, or it can be due to anemia of chronic disease, due to hepcidin, we discussed, right? So two things which we discussed is, yes, Dr. Shafiq, the first one was nutritional
Anemia.
deficiency and
Yes.
anemia of chronic disease. Let me just write it at ACD, right? Okay, so what happened as a result of that? Heme is going to be less, hemoglobin less. So red blood cell is going to undergo an extra division, which would lead to microcytic anemia, right? Okay.
Yep.
So this was the things which we discussed yesterday. So tomorrow we'll be just taking our discussion further that whenever we have defect in protoporphyrin synthesis, right? So it can also lead to less heme, less hemoglobin, less hemoglobin. It would lead to an extra division. Is that right? Hello?
Yes,
Yes.
Okay. Before just naming the pathology of the disease which we are going to discuss, first of all, let's discuss simply, right? So we have protoporphyrin. Can you guys just tell me how do protoporphyrin is made?
It's made from the.
Okay, perfect. So basically we have succinyl coenzyme, right? Succinyl coenzyme A, right? So succinyl coenzyme A is going to be converted into an intermediate that is basically known as ALA or amino levulinic acid, right? ALA.
Yes. Uh,
But they are going to use an enzyme for that. Yes, what's the name of that enzyme?
uh, uh, uh,
A
uh,
ALS.
Okay, perfect. That is ALA synthase, right? But in this process, they also requires Yes, a vitamin, that is vitamin B6 as a cofactor, right?
Yeah.
Hello? Okay, this is normal synthesis of your protoporphyrin. I'm discussing normal synthesis. So as I already told you, if you guys know the physiology, pathology is going to be really easy for you guys. So let's just start with the physiology, or let's start with the production of that, how protoporphyrin is basically made inside your body, right? So this is a synthesis, right? What happens? Succinyl coenzyme in the presence of ALA synthase and B6 as a cofactor is going to be converted into ALA or aminolevulinic acid, right? Right after that, another step, let's carry it on further. We're going to have formation of, yes, anyone?
Protoporphyrin.
Okay,
Protoporphyrin.
perfect. We have porphobilinogen, right? But this time we are going to use another enzyme for that, which is LALAD, that is aminolevulinic acid dehydrogenase, right? So let me just name it as aminolevulinic acid dehydrogenase, or LALAD. Is that right? Okay. Ultimately, then we are going to have a bunch of some other processes and other intermediate steps that aren't important, but in the end, we are going to see formation of protoporphyrins, right? And this protoporphyrin which we discuss is going to join with your iron, but this time it would be just using an enzyme. And what's the name of that? Ferrochelatase, right? Ferrochelatase. The idea is really simple. Ferro stands for iron, right? So this enzyme is going to incorporate your iron with your protoporphyrin, that is ferrochelatase, or we can say it's going to chelate. It's going to hold the iron and it's going to integrate it with your protoporphyrin, and as a result of that, we are going to see formation of heme part of your hemoglobin. Is that right?
Yes, doc.
Okay, perfect, right? Okay, so for example, if they undergo some like defective processes of the respective enzymes which we discussed, for example, if we have deficiency, genetic deficiency of ALA synthase. So Dr. Shafiq, can you just tell me that would this process be like carried on like as we discussed? Yes or no?
It will not happen. We'll
Okay,
get porphyria. We'll get porphyria.
okay, perfect. So what happens if we have deficiency of this enzyme? What happens? Can I say that protoporphyrin is going to be less? Okay, we can have inherited cause of deficiency, like the deficiency of this enzyme is going to be some inherited reason, or inherited or congenital defect, right? So congenital, for example, if you have an individual congenitally, he have absent or he have no ALA synthase. So what happens? We are going to have less protoporphyrin, again, just continue back the cycle, right? So heme is less, hemoglobin is less, microcytic anemia, cell is going to undergo an extra division. So can I say that this, if you guys got any questions in your UR that we have an individual congenitally, he do not have this enzyme, so which kind of anemia are we going to see? Is it right?
Sideroblastic.
That's okay, perfect. Sideroblastic anemia. We are going to discuss that in a while, right? Okay. For example, if basically we have lead, right? You guys are aware what is lead. So sometimes, like for example, you are going to see a UWorld MCQ, like in the past, basically the paints which we like use for our households, basically in the past they would contain lead, right? So what children do, for example, if they accidentally eat that paint, like for example, children, they just take everything and put it into their mouth. So what happens? They are going to be like suffering with a condition that is known as lead poisoning. And important point which you guys should know, the lead normally inside our body is going to inhibit some enzymes in the following pathway. So which enzymes does the lead inhibit? That is LALAD. Lead inhibit this enzyme, and ferrochelatase as well, right? So lead basically inhibit ferrochelatase as well. So can I say that whoever, for example, if you have a child you have a UWorld MCQ on that as well, that we have a child, he was just eating some paint, and as a result of that he developed porphyria, as we are going to discuss that in the next module. So can I say that this like child or this guy or anyone who have like toxicity with lead or poisoning would lead to development of microcytic anemia? Can I say that?
Yes, doc.
Okay, perfect. Okay, we discussed that we need vitamin B6 as well in this following pathway. So for example, if we have deficiency of vitamin B6, so can I say again it could lead to microcytic anemia? Just follow back the pathway.
Yes.
Okay, perfect, right? So, okay, so let's just carry on our discussion further, right? We know that protoporphyrin is basically added to your iron, or iron is basically added to protoporphyrin in your mitochondria, right? Hello?
Yes, yes, doctor.
By using an enzyme, ferrochelatase, right?
Yep.
Okay, perfect. So for example, if we have like these pathologies we discussed, for example, if we have like congenital absence of this enzyme or deficiency of B6, or we have like lead poisoning, so can I say that we won't be having sufficient amount of protoporphyrin? Can I say that protoporphyrin is going to be very less,
Yes.
right?
Yes.
But the iron is sufficient. So the idea is really simple. Iron is going to enter into mitochondria, but as iron enters mitochondria, he have no one to bind. So what happens? Iron is going to be trapped there, right? So iron is going to be trapped within the mitochondria because you do not have any, like the iron do not have any protoporphyrin to bind with. So can I say that the mitochondria is going to be overloaded with your irons?
Yes.
Perfect. So the iron once overloaded with the mitochondria overloaded with the iron or Fe, what would it do? It would just form a ring around your nucleus, right? So this is going to be a cell. You have your mitochondria, you have your iron, so it's going to form a ring around your nucleus, right? And inside that ring, we already know the iron is trapped, right? Why? Because iron do not have anyone to bind, right? So this ring is basically known as ring sideroblast, right?
Excellent.
Why?
Yes.
Okay,
Yes.
as a blast stand for the cell, sider, or we use the word siderin, if you guys remember, for iron, right? That is hemosiderin, right? Hello?
Yes.
Yes,
Okay,
doc. Yeah.
perfect. And as it is just forming a ring, so can I just, okay, again, if you do not have, okay, in this condition, we already know. Why do we have ring sideroblast? Because we do not have protoporphyrin. I already know that, right?
Yes.
Okay, and we already know whenever we have less protoporphyrin, we have less hemoglobin, we have microcytic anemia. So the anemia which is due to the ring sideroblast, let me just call it as sideroblastic anemia. So can I call it as sideroblastic anemia in order to make association and discussion way more easier?
Yes.
Okay, that's perfect, right? So this was all about your ring sideroblastic anemia or sideroblastic anemia. Let's discuss some lab findings which are going to be like really useful for you guys to solve your world, right? Okay, so lab findings. As we already know that the problem here is with your protoporphyrin, right? Protoporphyrin. Okay. We already know that the iron is sufficient. So let's discuss the labs which we discuss about the iron. We already know the concept of factories. We already know the concept of cars, and we already know the like ferritin, transferrin, and ferroportin, right? So for example, if I have sufficient amount of iron, because the problem here is not due to iron. So what would happen to the ferritin levels? Yes, please raise your
Hi.
hand. Okay, perfect. Ferritin is going to be high. If I have a lot of workers in the factory, so what happens to the cars? The cars are going to be low because you do not want extra workers. So what will happen to TIBC or transferrin of your cars?
Will be
Folate
low.
also
Low.
Low,
decrease.
perfect. Okay, what happens to the serum iron?
It will be also high.
It's high.
Perfect, it's also going to be high. Okay, so all of these labs you should be aware of that, right? So let me just give you a brief overview of the topic, and then we are going to like carry our discussion further, right? So we discussed microcytic anemia. We already know whenever the mean corpuscular volume is less than 80, it is considered to be microcytic anemia, right? So the main theme which we discuss is going to be like less hemoglobin. It's less hemoglobin which lead to microcytic anemia. That's the concept which we had. How can we have less hemoglobin? Whenever the components of the heme is less or the globin is less, it would lead to less hemoglobin. So what your red blood cell is going to do is going to undergo an extra division. So that's why we're going to have small or less MCV 80, that is microcytic anemia, right? So we discussed other causes. So we were just focusing on protoporphyrin, right? That protoporphyrin, we just discussed the relation that how could it lead to microcytic anemia, right? So the first point which we discuss is succinylcoenzyme is going to be converted into ALA, aminolenic acid, by using an enzyme, ALA synthase, and B6 cofactor, right? Then we discuss another enzyme, ALAD, that is, dehydratase, right? Simply, or dehydrogenase. Then we are going to have formation of protoporphyrin enzyme, ferrochelatase, which is going to integrate the iron into protoporphyrin. So any problems with the respective enzyme or the which we are discussing could lead to microcytic anemia. And here we were discussing the problems with ferrochelatase. Iron is going to be trapped within the mitochondria because they do not have anyone to bind, right? And as a result of that, it will just form a ring around the nucleus, which is known as ring sideroblast. Sidero for your iron, sidron, right? And in the end, you're going to have anemia, microcytic anemia, and we call that sideroblastic anemia. Is that clear?
Doctor, I
Yes,
have a
Doc,
question.
clear.
Yes, please. Any questions?
Yes, I have a question. So, what do we see in lead poisoning in the blood smear?
Okay, so basically there is a term used for that is basophilic stippling. You're just talking about that, right?
Yes, exactly. So, why do we see lead?
Okay, so basically we are going to have like structures which are known as basophilic stippling, right? So basically you're going to have like a remnant of some molecules within the red blood cells which are basically known as like which are going to be seen as basophilic, blue, right? So bluish color of things are going to be seen. So we'll just discuss that in a while once we just come to that, right? So we'll be having an entire explanation over that. Just don't worry about that. Write it down. We are going to discuss that. But till now, simply you should remember that ring sideroblast is characteristic. Okay, so no, sorry, the basophilic stippling. It's a characteristic feature of lead poisoning, right? Lead poisoning. And we are going to have bluish color remnant of RNA inside your red blood cells as a result of that. We'll just discuss the details, right? But till now, you should know that. So let's carry on. Is it clear, Dr. Alma?
Yes,
Hello?
thank you. Yes, thank you.
Okay. So let's just carry our discussion further. We have a big topic, thalassemia, which we have to cover, and macrocytic anemia. So let's discuss thalassemia, right? So just give me a second. So we discussed that whenever we have problems with the globin chain, it can also lead to microcytic anemia because hemoglobin is made both of your heme and globin. So let's discuss the globin part of this discussion, right? So Dr. Ilma, can you just tell me different globin chains present inside the globin? How do we classify them?
So we have alpha 2, alpha, beta.
You just wait and watch.
Okay, so the major one are going to be your alpha and beta,
And
right?
beta, yes.
So, okay, so the idea is same again. Whenever we have problems with these chains, alpha or beta, they are going to be the major one, right? The adult one, right? So whenever we are going to have problems with this, so what happens? Again, the hemoglobin is going to be less. Dr. Hazira, can you just please fix your mic? There is some voice, please. Hello. Okay, thank you so much. So what happens in thalassemia, the idea is very simple, right? Globin decrease, hemoglobin decrease, microcytic anemia, and extra division, right? So the major classification of the globin chains are going to be based on alpha and beta thalassemia because you have two chains, alpha chain and beta chain, right? So let's discuss alpha chain in a little bit detail, right? So we have different type of hemoglobin. You guys are already aware of that. We have fetal hemoglobin that have gamma chain instead of beta, right? And you already know that, right? We have hemoglobin A and hemoglobin A2, right? So A is going to be the most, important one which we are going to discuss, and A2 basically is present in the least amount, so we won't be focusing much on that, right? So hemoglobin A we are going to discuss is have two alpha and two beta chain, right? So let's discuss thalassemia. We discuss what is thalassemia whenever you have defect in alpha or beta chain, right? So the thalassemia in turn can be divided as alpha thalassemia or beta thalassemia. If there is problem with the alpha, we are going to name it as alpha thalassemia. Problems with the beta, we are going to classify it as beta thalassemia, right? So alpha thalassemia. Remember that the genes which encode for the alpha chain, they are basically present on chromosome number 16. Is that right? Hello?
Yes, Doctor.
Yes.
Right.
Okay. So basically what happens that this problem is going to be due to gene deletion, right? This problem is going to be due to gene deletion. What do we mean by gene deletion? That the gene is absent, right? So remember, we have 4 genes on 2 chromosomes, right? So we are going to have like 2 genes on 1 chromosome, and like both of these chromosomes are basically known as alleles, right? So we have like a total of 4 chains. They are basically present on one allele, right? Allele basically is a pair of chromosomes. Is that right? Hello?
Yes, right.
Which is
Yes,
like calling for same thing in this case, like alpha chain, right? So we have 4. We discussed that the problem in alpha thalassemia is due to deletion. What do we mean by deletion? That the gene is absent, it's deleted, right? So for example, Dr. Muskan ask you a question. For example, if we have deletion of this gene, which is encoding for alpha thalassemia, right? Deletion of a single gene. So for example, if you have an individual with this same case, so which kind of anemia are we going to see? Would it be mild or severe?
I think it should be mild.
Perfect. So we are going to have mild anemia because still we have three genes. Still we have three genes to encode for the formation of alpha chains, and there would be some mild anemia, right? But let's just carry on this discussion further. For example, if we have problems or deletion of two genes, right? Two genes. So now, what do you think would be the anemia which we'll be just seeing in this individual in the second case?
Moderate, kind of.
Okay, like it would be like a kind of moderate kind of anemia, but the problem with deletion of two gene can be like it can either be on same chromosome or it can either be on different chromosome. Like here we are just seeing it's deletion of two genes on same chromosome. And for example, this deletion can also be here, right? Not here, like it would be fine. So it's basically deletion of gene on
Different chromosome.
right? So the deletion of gene on same chromosome, what's the name used for that?
Cis?
Cis, perfect, cis. And for example, if we have deletion on the other chromosome, and for example, this one is paired, right? So this is going to be the cis form. Okay, let me just draw it. So this is going to be the cis form if we have like deletion on single chromosome, cis form. And for example, if this one is paired and we have like deletion on these two different chromosomes, this is going to be called as trans deletion, right?
Yes.
Okay, why are we discussing? Okay, cis basically stands like for the same side, cis for same, right? And trans for different. Is that right? So cis deletion is basically the idea is that you have deletion on same chromosome. But what's the problem with having cis or trans deletion, right? Okay, so the problem, for example, if you have an individual, for example, he has cis deletion, right? Let's suppose if we have a parent, for example, mother or father, right? What if she or he just pass this cis defective chromosome to like his or her offspring, right? So now there would be increased chances of having thalassemia in the offspring, right? Like for example, if this is a mother, let's suppose, and she passed this cis variant, right? And for example, if this child is so unfortunate, and even if he get a single mutated or deleted gene from his father, let's suppose, so he will be having three genes absent for your alpha. So you can have a severe form of thalassemia. Is that right?
Yes, right.
Yes, sir.
Okay. While on the other hand, if we have trans, right? So for the trans, we discussed that it's basically one is present on one chromosome and other deletion is on the next chromosome. What if you have mother with the same condition? If she passes this to her offspring, and if father by chance just for like pass the defected or the the bad chromosome this offspring, so there won't be like a sufficient anemia, or there won't be a big problem because now you are going to see two deleted genes. So is that right? So can I say that the cis is like bad for the offspring? Can I say that cis deletion is bad for offspring, right?
Yes, sir.
Okay. Whenever we have three gene deletion, it's going to lead to severe anemia, right? We do not have genes. If we do not have genes, so how do we make alpha chains? If you do not have alpha chains, we call it as alpha thalassemia. Alpha chain gone, hemoglobin gone, extra division, microcytic anemia. Is that clear? Hello?
Yes, sir.
Yes,
Okay,
sir.
perfect.
It's genetic disorder.
Sorry?
It's just like genetic disorders.
Yes, it's like a kind of genetic disorders associated with. Okay, I'll just do a review or overview. Just don't worry about that. But let's discuss the last case. The last case can be like, the idea is very simple. We have 4 chromosomes. Like, so we have 4 possibilities. Either we can have deletion of 1, either we can have deletion of 2. But in case of deletion of 2, again we have 2 possibilities. Either this deletion can be on the same chromosome, either it can be one on one chromosome and one on another. Like, we are just looking for the possibilities of deletion, right? Which can lead to the symptoms. Are you just clear now?
Yes.
Hello?
Yes.
Okay, perfect. Okay, that's perfect. Okay, so let's discuss the fourth possibility. What if we do not have any genes which is encoding for alpha chain? That is 4 genes being deleted. So what would happen? We know if 4 genes are deleted, what's the next chain present in the, like, okay, 4 genes are going to be, it's going to be a genetic problem, right? 4 genes being deleted. 4 genes being deleted, a genetic cause. So it means that the baby is going to be affected because genetically he do not have any gene for the alpha chain. So we discussed fetal hemoglobin. So Dr. Rebecca is going to tell us that yes, basically the hemoglobin or the globin chain inside the fetus. What's the chains? You have alpha and gamma chain, right?
Yes.
Yes.
Okay, perfect. So if you do not have any alpha chain, so 0 alpha chain, right? So what would gamma chains do? Gamma chains, okay, so we have alpha 2 and gamma 2, right? For your fetus. For example, if you do not have this alpha, why? Because all of the 4 chromosomes or the genes are absent. Is that right? So it means the remaining R2 or gamma 2 is going to combine with another gamma 2, right? And this collectively is going to form a complex. And what's the name of that complex? Or what's the name of this hemoglobin now? Yes, Dr. Shafiq?
Hemoglobin bath.
But, right? So it's a tetramer. You have 4 gamma chains now, right? Because you do not have alpha. And it's so highly toxic. It's so highly toxic to red blood cells that even it's going to end in a condition which is known as hydrocephalus, right? You're going to, like, the child in this case is like going to be dead, right? Why? Because if you do not have alpha chains, if you have only hemoglobin bar, so hemoglobin bar do not have the ability to, you know, transport oxygen. So you are going to see confirmed death of this child. Is that clear?
Clear.
Hello? Perfect,
Yes.
right? Okay, let me just give you an overview of the globin chains, alpha and the beta chain. So we discussed, we have like hemoglobin. We are discussing the globin chains, the globin, right? So globin basically have 2 chains, alpha and beta. Alpha, furtherly, alpha thalassemia. And what was the word thalassemia we use for? Defect in the globin chains, right? So if we have defect in the globin chain, that is simply known as thalassemia. But it can be due to 2 causes, either problem with the alpha chain or either problem with the beta chain. For the alpha chain, we discussed we are having chromosome, that is chromosome number 16, right? It's having like 4 genes, right? 2 alleles, or okay, single allele, like a pair of chromosome, which have like 4 genes, which encode for the production of alpha chains within the globin, right? So we can have different possibilities. For example, we can have deletion of a single, which is going to lead to mild anemia. We can have deletion of two genes, right? But again, in 2, we have 2 different possibilities. Either 2 of them are going to be deleted on the same chromosome, which is known as cis, or either they can be deleted on one chromosome and other on the other chromosome. Are you guys getting me? Hello?
Yes.
Yes.
Okay,
And called
perfect.
trans. Yeah.
Yes, that's called trans. What's the problem? Why are we discussing cis and why are we discussing trans? Because cis is bad for your offspring, right? Because it would be having more probability, or the child is going to have more, you know, he'll be prone to have anemia, like he'll have more chances to develop anemia, right? Or
Yes, right.
thalassemia. Okay, perfect. So let's just carry on our discussion further, and let's discuss the other variant of thalassemia, that is beta thalassemia, right? Okay, so let's discuss beta thalassemia. So it's going to be a little bit different than that of the discussion on alpha thalassemia, right? So we discuss alpha thalassemia. We have 4 genes encoding for your production of your alpha chain. But in case of beta, we have 2 genes, right? 2 genes. Okay, on which chromosome? Yes, Dr. Muskan.
11.
Perfect. Chromosome number 11, right? So we have 2 genes basically encoding for production of your beta chain, right? So what happens, we discussed that alpha thalassemia is going to be due to deletion, but this is going to be due to mutation, right? So if it's due to mutation, not deletion. So in the deletion we discussed, it's going to be deleted. If it's deleted, so no alpha. But in case of mutation, you cannot completely delete or you cannot completely diminish your B. Either you can, like, you can have 2 probabilities, right? Either you can have like normal B chain, or either you can have, like, you're going to have 3 possibilities. Either you can have B chains being made, but they're going to be less in number, right? Less in number. Or thirdly, the mutation can be such severe that you do not have any B. Is that clear? Like it depends upon like the extent of mutation, right? So this is going to be the normal. For example, if you have a little bit mutation, which is causing a little problem, so we can have less B. Is that clear? Less beta chains. Or if we have like a severe kind of mutation, it can lead to even absent B chains. Are you guys getting me? Hello?
Yes.
Hello? Okay,
Yes, sir.
perfect, right? So let's discuss the like two different extremes of the cases that we can have. So now okay, so in the alpha we were just discussing different probabilities, right? So now let's discuss different probabilities which we can have here, which can lead to beta thalassemia. So the one which we'll be discussing is that either we can have a normal one, right? Or we can have a defective one, but less defective, right? Like they're making B, but less in number. So what do you think if we have this case in an individual? So which kind of thalassemia are we going to be seeing? Would it be a minor or would it be a major?
Minor.
Minor.
Okay, minor or mildest, because this is normal, it's going to make normal and it's going to make less, right? On the other hand, for example, if we have another case that is okay, can you just please fix your mic, Dr. Judith, please? Okay, so for example, if we have case where we do not we have a severe mutated form of B chains which aren't making any B. So what do you think, which kind of anemia are you going to experience or see here?
Severe.
Severe.
Perfect. So we are going to have severe anemia, right? Severe anemia. Okay, again, we do not have B. Just let's take the equation back, right? We do not have beta chains or beta thalassemia, less globin, less hemoglobin, and extra division, microcytic anemia. Can I say that?
Yes.
Okay,
Can you
perfect.
please repeat the concept of mild and severe?
Okay, yes, perfect, right? So, okay, so let's just like carry our discussion a little bit further with condition. What we are going to see certain characteristic cells that are known as target cells, right? So anyone who can just tell me what are target cells?
So can you please repeat here?
Okay, so in the UWorld, you are going to see again and again a term used for the thalassemia, that is target cells, right? The beta thalassemia. So can anyone just tell me what are your target cells and what's the concept behind getting target cells?
The target cell is the hypochromic red blood cells.
Okay,
with
okay,
the-
hypochromic red blood cells. So what do we mean by hypochromic? Chromic basically stands for the color, right? And
Yes.
hypo, okay, let's just divide this name. Hypochromic. Can I say it's like the literal or direct definition of this term is going to be less color within the red blood cell, and the color in the red blood cell is basically provided by your hemoglobin. So ultimately, it means that you have less hemoglobin within your red blood cell. Hypochromic. Is that clear? It can be due
Yes.
to beta thalassemia. Okay, perfect. Yes, please carry on the discussion.
Yeah, and I think because the B chain is absent, that's why it's become like a ring. Is it?
Okay. Okay. So normally we discuss the normal structure that, for example, this is your red blood cells. So in the middle, basically, you are going to have a payload, right?
Yes.
Like, or on the other hand, in the mid, you won't be having any hemoglobin because the color is provided by hemoglobin. Can I say that?
Yep.
Okay. So for example, in this case, if I'm having less content within the red blood cell, right? You can simply assume it as a basketball, right? If I'm just removing some of the ear, so it would just become like a kind of like a soft and fluffy kind, right? So what happens now, the distribution of the volume or hemoglobin is going to be disrupted, right? So you can imagine it as a basketball and you're just removing some ear, right? Are you guys getting me? So what happens, the distribution of the remaining hemoglobin is going to be disrupted, and then you are going to see distribution of hemoglobin even in the middle, right? Normally it was we do not have any hemoglobin in the middle, but if you are just redistributing the volume by removing some of the like the hemoglobin, so what happens, this part is also going to be occupied by hemoglobin, which is going to be seen as target cell. You can see it's a target point within the red blood cell. Is that clear?
Yep.
Okay, that's perfect, right? So can anyone just give me a quick overview of beta thalassemia? Please raise your hands, those who want to participate, please. Okay, Dr. Kala. Yes, please.
Doc, can we get somebody to give us a recap of alpha thalassemia? Because we
Okay.
need to hear about the different types, if you don't mind.
Okay.
Yeah,
Yes.
again.
Yes. And okay, Dr. Shafiq, you can just do that, please.
No, I like to listen to it. That's why I asked.
Okay. Okay. No problem. Yes, please. Anyone who just want to help Dr. Shafiq with, or who want to have discussion with Dr. Shafiq, Dr. Mariam, yes, please help us.
Yes, for the alpha thalassemia, you said that there are the 4 alpha genes. So if one gene is deleted, so what will happen? It will be the minor alpha thalassemia. If 2 genes will be deleted, there will also be the minor. But if the 2 of the mother side and will be deleted, it will be the cis type, and that will be severe. But if the 2 alpha will be from both sides, then it will not be so severe. That will be the trans thalassemia. So, and if the 3 alpha will be deleted, so that will be the hemoglobin H, and that is also the severe condition. And if the 4 alpha genes will be deleted, then it will be the hemoglobin part disease, and that is more so severe, and that is not incompatible with the life.
Yeah, hydrops vitalis. Thank you,
And
Doc. I
hydrops fetalis.
I
Yeah.
got it.
Thank
I
you
got
so
it.
much,
Thank
Dr.
you.
Mariam. Dr.
Yeah.
Mariam, can you just please give us an overview of beta thalassemia as well?
Yes, and in case of the beta thalassemia, there are the 3 genes of the beta. B is the normal, B plus is the minor, means some abnormality, and the B naught is the mutated B. So
Yeah, severely mutated with absent or with the no ability to form some like beta chain, so it's going to be the severe form, right?
yes, sure. So if the B and the B plus will be there, it will be the mild beta thalassemia minor, and here is the mild microcytic anemia. And if the both beta genes will be mutated, it will be the severe beta thalassemia, and it is the beta thalassemia major, and we will have the microcytic anemia. And if we one will be the minor, one will be the B plus, and other beta will be mutated, then it will be mild to moderate, means intermediate, and we will
Okay.
not have the severe
Okay.
conditions. Yes.
That's perfect. That's perfect. So let's discuss another concept of like extramedullary hematopoiesis, right? So this is going to be like a simple concept, I would say. Okay, for example, can I say that if we have like alpha or if we have beta thalassemia, right? So we cannot make enough hemoglobin, right? And we discuss hemoglobin is so important because it's the hemoglobin component of your red blood cell which transport oxygen. And if you do not have hemoglobin in the respective like cases which we discuss in the thalassemia, so it could like lead to a lot of problems, hypoxia, right? Even death. Can I say that?
Yes.
Okay, so now your body is in danger. You do not have any hemoglobin. So what your body is going to do? It's going to tell your bone marrow. Okay, so like the function of your bone marrow to make red blood cell, right? So your body is going to like tell your bone marrow, I need a lot of red blood cell. Do something, right? But as we have problems within the like genetic problems, right? Your body cannot do anything. So what happens that your body is going to call those places, like where do primitive hematopoiesis took place? Yes, Dr. Shafiq, what do you think? Like in the normal individual, it takes place in the bone marrow, right? But in the primitive stages, there were
Yes.
some different points, or there were some like different places where this hematopoiesis took place. Can you just recall that?
Yeah, they will. He will ask some extra pyramidal, what is extra hemopoietic tissues to help in the production of red blood cells. Yeah.
Perfect. Okay. Okay. So what do you mean by extramedullary hematopoiesis? Now your body is going to tell even to those places or those structure where our primitive red blood cells or hemoglobin was made, right? Even in your skull bone, it's going to tell your skull bones to just please provide me with some
Red blood
provide me
cells.
with some red blood cells. Like your body is going to tell your spleen, provide me with some red blood cells, because that was also a primitive area where we used to make red blood cell for our small little baby, right? So now your body is going to be like in a severe crisis. It's going to call all of the areas where, like in the past or in the primitive stages, hematopoiesis took place. So this is basically known as extramedullary, right? What do we mean by extramedullary? We have a bone, right? And we know in the
Yes.
bone we have marrow, right? And that marrow part is basically known as medulla of the bone, right?
Yes.
Okay. So what do you mean by extramedullary? Other than medulla, other than bone marrow, which structures?
Liver
Yes.
spleen.
Skull, your spleen, even your liver, right?
Yes.
And what else? Okay, so these are going to be the area, right? So whenever the hematopoiesis or the erythropoietin, like your skull, it will be just in an attempt to make some red blood cell for you guys, because your body is like in a severe danger, in severe crisis. What happens? Your skull is going to become hyperplastic, as we already discussed. Whenever the functioning of the cells is increased, it leads to hyperplasia, right? Like for example, in the Cushing syndrome, in the Cushing disease we discussed, if we have a lot of stimulus coming from your brain, a lot of ACTH is going to lead to hyperplasia, right? It's going to lead to hyperplasia of your adrenals, right? So it means
Yes.
that if you are working hard, if you are working more, things are going to become hyperplastic. So now, if your skull is working more, if your skull is like compelled to make more red blood cell, you're going to have hyperplasia of your skin, the erythroid hyperplasia, which is going to lead to an appearance which is known as crew cut appearance, right? So on imaging, you're going to see it's like crew cut appearance, right? Which basically indicates the extra effort which your skull is bone is putting in order to make some red blood cell, and it would just appear in the form of crew cut appearance. Is it clear?
Yes.
Okay. Okay, it's also going to tell spleen to please just make some more red blood cells. So can I say it can, like we can also see splenomegaly?
Yes. Okay.
Okay, perfect. What else we can see? Hepatomegaly as well, because it's also going to tell the liver to make some red blood cells for me, because the body is in crisis. Hello?
Yes.
Okay, perfect. So
Yeah, and there will be chipmunk face.
yes, chipmunk face, because the facial bones, perfect. The facial bone were also, important in hematopoiesis, right? So it will also tell your facial bone to please just, give me some red blood cells, give me some hemoglobin. I'm just, in some crisis. So the facial bones are also going to become hyperplastic, which would appear in the form of chipmunk faces. Is that clear?
Yes, clear.
Okay, perfect, right? So let's discuss our next topic, our last topic for today, I would say, that is macrocytic anemia, right? So the macrocytic anemia is going to be really simple. If you guys remember, I just gave you a chart, which I just told you we are going to discuss the same thing in macrocytic anemia, right? So what was your macrocytic anemia in the first place? Macrocytic anemia, macrocytic anemia. Yeah, Dr. Shafiq, what do the term macrocytic anemia suggest? What do you think?
Means that the red blood cells is large, more than the normal limit, which is 100.
Perfect. So it would be greater than 100, right? Okay. So let's just make a story for macrocytic anemia as well. As we just made a story that we are going to have an extra division whenever we have less things, right? Which is going to be. So let's just make a story for macrocytic anemia, right? Okay. So can you just tell me, Dr. Dr. Muskan, can you just tell me, can I say that for my cells to undergo division, I need DNA? Can I say that?
Yes.
Okay. If I need my cells to undergo division, I would need DNA for that.
Yes.
Okay. So can I say if my cells do not have DNA, it cannot undergo division? Can I say that?
Yes.
Okay, let me just, modify my statement. Can I say that anything which leads to problem within the DNA, anything which leads to problem within the DNA is directly related to this statement, which I stated, would lead to less division, right?
Yes.
Okay, perfect. So the story here is that anything which lead to problems within the DNA, what happens? Your cell cannot divide. So it would just stay big if it cannot divide normally. If you have less DNA, or the things or the problems which are contributing in, defective or less DNA, it would lead to less cell division, which is going to appear as macrocytic anemia. Can I say that?
Yes.
Okay.
Sorry, can
Yes.
you repeat from the start of
Okay,
macrocytic?
perfect. Okay, no problem, right? So we discussed we have our cell, right? In order for the cellular division, we know the process of cellular division. How do cell divide? We have different phases for that, right? Yes. Can anyone just go back into the medical school and tell us
Pro
some of the process
Metaphase.
of mitosis,
We have 4 phases.
prophase, anaphase, telophase, cytokinesis, right? And
Yes.
you know, DNA was responsible for that. So can I
Yes.
simply say that for cellular division, we need DNA? Yes, can I say that?
Yes.
Okay, anything. Okay, so if I have just set up this statement, so this statement can be modified, and it can be said that anything which leads to problem with DNA would cause less cellular division. Can I say that?
Yes.
Okay, if I have less cellular division, the cell is going to appear big because it isn't dividing. Hello?
Yes.
Hello?
Agree.
Sure.
Okay,
Yes.
big cell is also known as macrocyte, right? Or let me just call it as macrocytic anemia, right? So the idea is the causes or the reasons which we are going to discuss in macrocytic anemia is directly going to lead to problems within the DNA. Is that clear?
Yeah. Mhm.
Okay, so what can be the problems with DNA? Normally, we know we need folate for DNA to form. Is that clear? We discussed how. Hello, can you guys, are you guys able to understand? Hello?
Yes.
Hello? Okay, we discussed a cycle, if you guys remember, right? We discussed that we have folate. Folate normally is binded to methyl. We discussed, right? So in order for the folate to participate in your DNA synthesis, it's going to give its methyl to B12. We discussed that, right?
Yes.
Okay. We further discussed that in order for the B12 to participate in certain processes, it had to give the methyl to homocysteine, right? Hello? And it's going to convert homocysteine
Yes.
into methionine, which is important because homocysteine buildup can cause endothelial damage, which can be like, it would be just confirming one of component of Virchow triad, which can lead to thrombosis. Can I say that?
Correct.
Yes.
Okay, perfect. So can I say that, for example, if I do not have folate, if I have problem with the folate, I will be having problems with DNA. Can I say that? Because I need folate for,
Yes.
okay, perfect.
For division.
If I do not have DNA, it's going to lead to less cellular division. It would lead to macrocytic anemia, simple. So can I say that folate deficiency is going to lead to macrocytic anemia? Yes or no?
Yes.
Yes.
Yes, doc.
Okay, that's perfect, right? So one of the cause is folate deficiency, which we are going to discuss. Okay, let's discuss another cause. For example, if I do not have B12, right? It means that folate have no one to give its methyl group. Is that right? Hello?
Yes. Right.
Yeah.
Okay, so it means that this compound or complex cannot participate in DNA synthesis, right? Because in order to participate in DNA synthesis, in order for the folate to participate in DNA synthesis, it must give its methyl group to B12. Is that clear?
Yes.
If I do not have B12, if I do not have B12, again, folate would not participate in DNA synthesis. Is that clear?
Yes.
It isn't participating in DNA synthesis. Again, you're going to have less cellular division and macrocytic anemia. Can I say that?
Yes.
All right.
doc.
Okay, that's so perfect. So other cause is going to be our B12 deficiency. Now you guys are pro at microcytic and macrocytic anemia. The concepts, you guys know that how do it lead to macrocytic or microcytic anemia? Hello?
Yes.
Let's discuss folate deficiency in a little bit more detail, right? So it was just a mind map or a road map which we just made for the pathologies which we are going to discuss. And while solving you work, like it's going to help you a lot because USMLE do not only test the information you have that you know that this is this. No, like it tests the interconnection of different concepts, right? That you guys
Okay.
should know that how to interconnect one disease with another, how to connect like iron deficiency. So you should be having like this road or this connection between different pathologies. So all of this, this is going to be the main idea of your real exam. Okay, so let's discuss folate deficiency in a little bit detail, right? So can you guys just tell me that where do we find folate, in which kind of food?
Green vegetables.
Green vegetables, green leaves.
Perfect. So in the green vegetables, right? Can you just tell me where do folate reabsorption occurs?
Section.
The jejunum.
Okay. Okay. So can I say that, for example, those individuals who are just taking less intake of green vegetables and fruits are going to have folate deficiency? Can I say that?
Yes.
Again, folate deficiency would lead to less DNA synthesis, macrocytic anemia. Can I say that?
Yes, sir.
Right.
Okay. But important point, we are going to have less cellular division, right? As we discussed, if we have less DNA, but this concept cannot be only applicable to red blood cells. Is that clear? If you have less DNA throughout your body, it means that cells throughout your body are going to be affected. And which kind of cells? Actively dividing cells. Actively dividing cells are going to be compromised due to less division, due to less DNA or less division, right? And red blood cells is like among those actively dividing cells. So you are also going to see some enterocytes or epithelial cells being affected, like neutrophils also, right? So not only you are going to see big red blood cells, but you are going to see big neutrophils, right? And how to like confirm whether the neutrophil is big? It would be having more lobes, right? So you have a U and MCQ on that. They are going to give you a clear picture of neutrophil, right? How to confirm neutrophils? You are going to look for the lobes. If the lobes are more than 5, it means that it's hypersegmented neutrophil, which suggests problems with DNA, less division. It can be folate deficiency. It can be B12 deficiency. Is it clear?
Yep.
Yes,
So you
clear.
have a UL MCQ on that. Similarly, epithelial cells are also actively dividing cells. They also need the activity of DNA, right? So any problems leading to defective DNA, less division, further leading to like big enterocytes, right? Or big epithelial cells. Is that clear? So let's discuss the concept of folate. So we already discussed it's basically reabsorbed in the jejunum. We discuss, okay, we have different drugs that is folate antagonist, right? If you guys remember methotrexate, right?
Phenytoin. Phenytoin.
Hello?
Phenytoin.
Yes,
Yes.
phenytoin. Right. So can we say that, for example, if someone is using those drugs, the idea is it is also going to lead to less folate, again, macrocytic. Can I say that?
Yes, sir.
Okay, perfect, right? So let's discuss our last topic for today, that is vitamin B12 deficiency. So I think it's going to be like a simple one, and you guys already know that. Okay, let's discuss it in a little bit detail, right? B12 deficiency, because we are going to see same topic in GI, so it's better to know some of the details, right? So vitamin B12. We discussed that vitamin B12 is like an important, intermediate of the step which we discussed here, right? It can lead to a lot of problems. Hello?
Yes.
Okay. So let's discuss that how do like vitamin B12 get absorbed, right? So for example, if we just take like some food which contain like animal derived protein, basically contain a lot of vitamin B12, right? So for example, if we just take vitamin B12 into our mouth, so in the mouth, it's going to be attached with a certain binder, which is known as R binder, right? So B12 is going to attach to R binder in your mouth, right?
Yes.
Okay. Once it go down into your stomach, your stomach have parietal cells. We discussed that, right?
Yes.
Parietal cells basically make your H plus and intrinsic factor, right? Are you guys just following me? Hello?
Yes, sir.
Yes, sir.
Okay. So what happens now? You need B12. Okay, now we have B12 with R binder, right? So you need intrinsic factor to bind to B12, because without B12 binded to intrinsic factor, you cannot reabsorb it in the ileum. You guys already know that. Hello?
Yes, sir.
Okay, but before for the intrinsic factor to bind with B12, first of all, we have to remove R binder, right?
Yes, sir.
Okay, how do we remove R binder? Pancreatic enzymes does that. Pancreatic enzymes would remove the R binder, and then your intrinsic factor is going to be attached to your B12, and this complex is going to be reabsorbed in your ileum. and you need B12, right? We discussed why do we need B12 for the pathways which we discussed in order to for the homocysteine not to be built, in order for the DNA synthesis. Is that clear?
Yes,
Yeah.
yes.
Okay, perfect. So can I say
Can you
that-
repeat this concept?
okay, don't worry. I'm going to repeat it, right? Okay, so we have vitamin B12. From where do we get vitamin B12? It's mainly like derived from animal products, right? Animal derived proteins, right? Once we just take vitamin B12, our salivary glands are first of all going to, for example, if I'm just taking, I'm just consuming some meat. So our salivary glands are going to, remove the B12 from that meat, right? First of all, because we need B12. In your mouth, you can simply think of, in your salivary gland, you have R binder. It's going to attach R binder to your B12 here, right? All of this happens in your salivary glands, right? Or in your mouth, simply you can think of. Is that clear?
Yes, sir.
R binder now is, okay, B12 attached to R binder is now going to go into stomach, right?
Yes,
It's gonna be elevate. It's gonna be cleaved from R factors.
Yes. So first of all, we need to cleave the R binder from your or R factor from B12 and attach intrinsic factor to B12, because
Yeah.
without attachment of intrinsic factor to B12, you cannot reabsorb B12, right? You will be deficit at B12. You'll be having a lot of problems. That is macrocytic anemia. You can have thrombosis. We discussed that, right? But in
Yes.
order to
Okay,
remove
one thing,
R binder,
doctor.
perfect. So which enzymes basically help in the removal of R binder? Pancreatic enzyme. Is that clear?
Yes.
Okay. So can I say that? Okay. So let me just make a concept or make an association with it. Can I say that pancreatic insufficiency would lead to macrocytic anemia? Yes or no?
Yes.
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 Okay. Those who want to say that yes, please raise your hand. Who are in favor? Okay. So Dr. Divanchi, can you just please tell us why? Why are you just supporting your statement that pancreatic insufficiency is leading to macrocytic anemia? Why?
Because then those vitamins which are forming in the pancreas won't be able to reach because of the pancreatic insufficiency. They won't be able to digest and do
Okay.
their function.
Okay. Can I simply say that if you have pancreatic insufficiency, I cannot remove R binder, right? From B12.
Oh, yes.
I cannot remove R binder from B12. I cannot attach intrinsic factor. So it means B12 won't be absorbed. It means we have less B12. If you have less B12, you have less DNA synthesis. If you have less DNA synthesis, it's going to lead to macrocytic anemia. Can I simply say that?
Yes.
Okay, perfect. For example, if I have a condition in autoimmune destruction of parietal cell, right? Can it lead to macrocytic anemia?
Yes.
Okay,
Yes.
those who, okay, yes, Dr. Muskan, why do you think?
Doctor, I think that yes, it's gonna lead to this situation, because I think there will be the problem, I mean, insufficiency or deficiency of intrinsic factor. So when it will not be able to bind further with the intrinsic factor, then how it's gonna absorb?
Yes, perfect. If you do not have parietal cells, we do not have intrinsic factor. If you do not have intrinsic factor, you cannot have reabsorption of B12, no reabsorption of B12. It means less DNA synthesis, macrocytic anemia. Is that clear?
Yes.
Okay, if you have problems with the ileum, that's the place where your B12 is going to be absorbed, right? For example, Crohn's disease. Again, can I say it can lead to macrocytic anemia, hypersegmented neutrophil as well? Don't just, forget that.
Yes.
Okay,
Yes.
perfect.
Yes.
And you cannot forget the discussion of thrombosis. If you do not have B12, you'll be having more homocysteine, more endothelial damage. One of the criteria of your Vircotide, it's going to be satisfied, which is going to lead to thrombosis. So this was all about today's lecture. Hope so you guys enjoyed. I just tried my best to make these discussions so simple as I can. And with that, our discussion is, ended. And let me just take some rest. Before going, did you guys enjoy today's session, today's lecture? Hello?
Yes,
Yes,
doctor.
sir.
Yes, sir.
Thank you so much, doctor.
Okay.
Yes,
Thank
we
you so much.
appreciate that. Thank you, sir.
Okay, thank you so much for staying here and making this discussion valuable. Okay, so before leaving, I want you guys to just complete the remaining new word questions. So who is going to help
Yes, please.
us? Yes, who is going to help us by sharing their UWorld screen and, completing of the remaining discussion. Yes, please.
I'm gonna do it, sir.
Yes, perfect. You can just please do that and just discuss the MCQs. I'm just sitting here and I'm just listening to you guys.
Ahmad, can you send us a PDF for this lecture? Not
Yes, I'll just send. Oh, yes, we have recording. I'll just
like
send the
not.
recording. Right. So
Not,
recording.
we need it not. If not, better for us. Recording is
Yes.
video.
Okay, so I'll just send the recordings as well as the the lecture notes, kind of the roadmaps
Thank you.
which we discussed.
Okay.
Okay. So we already we have some of the MCQs remaining. So I want you guys to complete that and then just go and get your sleep done and just wait for tomorrow's task. Wait for Dr. Mahin, and tomorrow we are going to finish the red blood cell module. That is going to be finished, and right after that we'll be starting with white blood cells. So we are going to make that discussion so simple, so easier again. And with that we'll be having an assessment, and that's all for the hematology section. So the next one is going to be our MSK, right? So get fresh for your tomorrow's class, but please just do complete the remaining discussion. Thank you so much. Thank you so much. Have a nice day. Bye bye.
Thank you so much, Dr. Ahmad.
Yeah, let's continue with the questions.
Sorry to interrupt. When did sir said about the assessment?
When we finish, I don't know. He didn't specify a date.
Okay.
He said after doing the white blood cells.
Hello, hello, hello.
Thank you.
Hello.
Yes.
Yeah, so assessment will be once we are done with the white blood cell module, okay? So it will be like after 5 days.
Okay,
and
thank
after the assessment, you guys will get 1 day of kitchen day, okay?
Okay, thank you.
Yeah.
Yeah, you guys can continue now.
Can I read?
Yeah.
Who is sharing the screen?
Somebody read.